And he really is someone that I'm honored to call him. So Dr. Garrido.
Thanks, well done for such a nice introduction. I definitely don't consider myself that, but I very much appreciate those comments. Thanks, Dr. Shah, also for the opportunity to speak today. Going back to the issue about Dr. G, the reason I asked my patients to call me Dr. G was because they were calling me any sort of funny names in the clinic, from Dr. Burrito, Dr. Burrito, and so on. So I said, let's keep it easy. But you have a beautiful last name that everyone can beautifully say. So these are my disclosures. These are my disclosures, and they are all relative to my involvement in clinical trials at the University of Utah. So ASCO this year has been a great year for research in pancreatic cancer. So most of what I'm going to be discussing are going to be clinical trials that have been presented in pancreatic cancer that change the standard of care or have a deep impact on how we approach our patients. And then I will briefly comment about a molecule, another antibody drug conjugate that was presented on a phase 1 trial that has shown also promising activity in HER2-positive gastric cancer. So I presented this slide last year, and this is not a good exercise to make because we're sort of doing some cross-trial comparisons, but I think it gives us a good sense of what has been the progress in the adjuvant setting for pancreatic cancer in the last 40 years. And you can see this as glass half empty or nearly full, because of course the line is nearly flat, but there's some clear progress because the 5-year survival rate has nearly doubled until the results of the SPAC4 trial were presented last year. So I was told to have a few questions, and I don't know if we have an answer system or we can just quickly go through this, but this is the first question. 67-year-old gentleman with a 3-centimeter adenocarcinoma in the head of the pancreas, status post Whipple procedure, who presents to your clinic with a negative margin resection, excellent performance status, and no significant comorbidities. So what treatment would you offer to this patient? Gemcitabine plus capecitabine, 6 months, based on SPAC4 trial presented last year. Full doses of FOLFIRINOX with growth factor support for 6 months. Modified FOLFIRINOX without bolus for 6 months. Modified FOLFIRINOX without bolus and with attenuated irinotecan for 6 months. Or gemabraxine for 6 months. So whenever you have answers that are very similar, you can easily kind of rule out A and E, right? You have 3 answers with FOLFIRINOX, so likely the answer is going to be among them. Now, we know that FOLFIRINOX is toxic, so probably full doses of FOLFIRINOX will not be the answer. And the key issue is, what do you think are the relevant toxicities with FOLFIRINOX? Is the issue only hematologic toxicity, and then we can sort that out by just dropping the bolus 5-FU? Or are we also concerned about GI toxicities, and then we also need to attenuate the irinotecan? And we'll get to the answer. Oh, that's an unwanted bulb. Okay, so we're doing this now. Okay. Wow. That's not the answer. How many people answered the poll? Do we know how many people answered the poll or not? We don't? Okay, I hope it was only one. Okay. So, what? Okay, 50-50. So, that's...
They're starting to answer. They're coming in.
Okay. Well, the answer, I guess I can answer this with the next few slides. So this was the PRODIGE study, PRODIGE 24 study that was presented recently at ASCO. And as you can see, this was a study for patients with resected pancreatic cancer with positive or negative margins Very important, they have a CA19-9 that had to be less than 180, and we'll discuss later why this is important, because this cutoff, it's certainly different to the cutoff that was used on the SPAC4 trial. And also, very importantly, they need to have a post-op CAT scan that was clear. This was not a requirement for the SPAC4 trial. Patients were randomized to FOLFIRINOX and gemcitabine, and you can see here that after around 160 patients had been treated, they had to attenuate the doses of irinotecan from 180 to 150. And this was because of a high incidence of grade 3/4 diarrhea, close to 20%. So that gives you the answer to the question before. We need to attenuate both, or drop the bolus 5-FU and also attenuate the irinotecan. Now, the treatment arms were well balanced. If you look at percentage of positive lymph nodes, close to 75% on both, and same for positive margins, close to 45% on both arms. Importantly, there was no difference in febrile neutropenia or incidence of grade 3/4 neutropenia, but that was only possible because of the use of secondary prophylaxis with colony-stimulating factors. You can see close to 60% of the patients on FOLFIRINOX received secondary prophylaxis with CSF. Now, obviously increased toxicities with FOLFIRINOX when you look at every toxicity from GI, hematologic, and so on. Importantly, the dose intensity of FOLFIRINOX, you can see that roughly close to 50% of the patients were able to receive dose intensity higher than 70% compared to gemcitabine, much better tolerated, dose intensity in the range of 90%. And this is the efficacy data. And this is actually some of the most impressive data, or definitely the most impressive data I have seen in the adjuvant setting in this disease. And many of us were shocked that this was not actually a plenary session at ASCO. Disease-free survival, you can see 21 months for FOLFIRINOX, 13 months for single-agent gemcitabine, 3-year disease-free survival rate. You can see that doubles from 20% to 40%. Overall survival, again, very significant improvement from 35 months with gemcitabine to 54.4 months with FOLFIRINOX. Now, this is the data I just plotted, the data for the GEMCAP trial for single-agent gemcitabine. And the reason I plot this was because we talk about disease-free survival on this study for the control arm. 13 months was similar to the disease-free survival for the control arm on the GEMCAP study, also 13 months. However, the overall survival for the gemcitabine arm in this study was 35 months right here, and this was a 10-month improvement compared to the gemcitabine single-agent arm on the GEMCAP study. Now, what are the reasons for that? Very likely the use of salvage chemotherapy. We don't have that data from the PRODIGE trial, but we know from the GEMCAP study that only 33% of those patients in UK receive salvage chemotherapy at the time of relapse. That certainly compares very different to the data from Japanese trial where 70% of the patients had received second line. And I'm sure that use of salvage chemotherapy on the PRODIGE trial, whenever it's reported, it's going to be higher than this one. Of course, there's now better treatments at the time of progression, and that also has an impact in the overall survival data. Now, so what is my take on PRODIGE? Definitely a new standard of care. It's hard to argue against that, right? Looking at this improvement in overall survival. What version of FOLFIRINOX will be using? So they use attenuated FOLFIRINOX, also decreasing the dose of irinotecan, and even with that, the median dose intensity was only 70%. So we need to be mindful in the clinic when we treat these patients. And then that also brings me to the palliative setting, where we have someone who we are treating with palliative intention. What is the role of using full dose FOLFIRINOX? I don't do it. So I think that we need to attenuate this regimen because those attenuations do not seem to impact efficacy of the treatment, and they may have a significant impact in the quality of life for these patients. And of course, we need to wait the results of the APAC trial, because this may establish a new standard of care in the adjuvant setting. So within the next year, we may have 3 options for our patients: FOLFIRINOX, gemcitabine, capecitabine, and maybe gemcitabine Abraxane, pending the results of this trial. So we will need to individualize treatment also for these patients, and it's actually quite rewarding to see that now we may have different options to pick up on these patients. So which one is true for borderline resectable pancreatic cancer? Randomized trials have failed to show a benefit in survival with neoadjuvant strategies. R0 resections are not increased when we do neoadjuvant treatments. Patients with borderline resectable pancreatic cancer should receive systemic chemotherapy up front, or neoadjuvant chemoradiation with single-agent gemcitabine is a standard of care. Patients with borderline resectable pancreatic cancer chemotherapy up front for reasons that we will be discussing. So in the last decade, we